The next set of disorders that we're going to talk about are cardiac dysrhythmias, also called arrhythmias, and congestive heart failure. So cardiac dysrhythmias or arrhythmias are deviations from normal cardiac rate or rhythm. They can be caused by electrolyte abnormalities, fever, hypoxia, stress, infection, or drug toxicity. Electrocardiography for monitoring the conduction system helps to detect abnormalities. So when you have those dysrhythmias, you get a reduction in the efficiency of the heart's pumping cycle. And there are lots of different types of abnormal conduction patterns. So on the EKG strip that's shown below here, it's a premature ventricular contraction, which is called a PVC. So when the ventricle contracts prematurely, it doesn't have time to fill up, and so you have less blood going out. It reduces your cardiac output. It also can cause some backup because the blood in the atrium didn't get time to drain all the way out. This is a pattern that will if they see this pattern, they will defibrillate you because they want to get your heart rhythm back to normal. So sinus node abnormalities, since the sinus node is the pacemaker of the heart, it can alter the rate of your heart rate. So bradycardia is a regular but slow rate. Tachycardia is a regular but rapid rate. And sixth sinus syndrome alternates back and forth between bradycardia and tachycardia, and a lot of times it requires that they put a pacemaker in because the sinoatrial node is not doing its job. So with atrial abnormalities, you can get premature atrial contractions or premature atrial beats, where there are extra contractions, and the atrial muscle is described as irritable because there are cells that are not contracting in time with the regular conduction of the heart. So if the atrial heart rate is between 160 to 350, which just sounds crazy fast, it's considered atrial flutter. And when you look at the little EKG strip there, it's the bottom one, that sawtooth pattern. The atrioventricular node delays conduction, and the ventricular rate is a lot slower than that. So it really messes up your blood flow. Atrial fibrillation is when the rate's over 350 beats a minute, and it causes pooling of blood in the atria, and then you have the risk of forming a thrombus. That can be a really big problem. So obviously, if you're in atrial fibrillation, you got to go see someone. You got to go to the emergency room. You got to go see a cardiologist. So they will, a lot of times, they'll prevent it. They'll treat it with medications. So heart blocks are where the conduction is either excessively delayed or stopped at the AV node or the bundle of His. There are different degrees of blockage. They call it first degree block, which is a delay between the atrial and ventricular contractions. Second degree, and sometimes there aren't any symptoms with that. Second degree block, every second to third atrial beat is dropped at the AV node, so the ventricles aren't contracting as many times as the atria are. Third degree block, and there are two different levels of second degree block. Third degree block, there's no transmission from the atria to the ventricles. So the atria are contracting and the ventricles are not. This is a bad thing, obviously. So I was looking on the internet and I saw this heart block poem, which I thought was pretty funny. It's like a little mnemonic for nurses again. We don't really have to know these, but when I find something that's funny or amusing, it sticks in my head more. And so I like to put these things in here. So they looking at the EKG, they say if the R is far from P, then you have a first degree. So the R is the peak of the QRS, and that is the ventricular contraction. The P is the atrial contraction. So if the R is far from the P, then you have a first degree. There's a delay. Longer drop, then you have a Wenkenbach. And so that's where it drops every third one. That's the second degree. The Mobitz 2 is the second part of second degree. If some P's don't get through, then you have a Mobitz 2. So the ventricles aren't contracting every time. If P's and Q's don't agree, then you have a third degree. So you get atrial contraction with no ventricle contraction. Anyway, kind of cute. So a bundle branch block is interference with conduction in one of the bundle branches. So you'll have one of the one of the ventricles contract and the other one doesn't, something like that. Ventricular tachycardia reduces cardiac output because there's no time for the heart to relax. You don't have any diastole; it can't fill as efficiently. Ventricular fibrillation, the muscle fibers contract independently and rapidly, and that can cause your heart to stop if it's not treated immediately, because there's no time for the heart to fill, the muscle fibers aren't coordinated, and things go downhill fast. And then the premature ventricular contractions we looked at earlier, there are additional beats from the ventricular muscle cells or an ectopic pacemaker, meaning some other source is causing that contraction, and you can get ventricular fibrillation with that as well. So a lot of times when you have a conduction abnormality, it can cause your heart to stop. The automated external defibrillators, which hopefully in your CPR training recently you got to use an AED, and if you haven't yet, hopefully you'll be able to do that soon. They're all over the place now. You can buy them on Amazon. But if you're at the mall, there's probably an AED in the security office. Swimming pools have them. There's one at the Health Professions Education Center. It's in Luann's office. So the AED, that helps you. It helps diagnose and fix a cardiac dysrhythmia. So with the AED, you put two electrodes on. It tells you it analyzes. It tells you whether the person needs to be shocked or not. If they do, you administer the shock right there. And 911's already on the way because you've already called them. And the AED could save someone's life. So it's pretty cool that we have those now. So this is the chart from the book that describes the different cardiac dysrhythmias. Boy, that word can get you. But at the best, they reduce cardiac output. At the worst, they could stop your heart. So none of these are good. When in the treatment of cardiac dysrhythmias, like a lot of things, they have to determine the cause and then treat that. A lot of times they use antidysrhythmic drugs. There are definitely some drugs out there that they use for atrial fibrillation and for some other things. With sinoatrial node problems or total heart block, they might require that you get a pacemaker. In the picture here, it's an x-ray of someone who's had a pacemaker implanted. You can see that pacemaker in their chest. They also implant a defibrillator for cardioversion of ventricular fibrillation. So it's called an ICD, which is called an implanted cardioverter defibrillator. So one time I was working on the cardiac wing at the hospital, and I was working with a really nice man that had just had an ICD implanted. He was really looking forward to going home and walking his dog, and he was supposed to be discharged the day that I was working with him. The second day, I worked with him the day before as well, and he was so excited about it, and we were going to go walk and do the stairs because he had stairs at home that he had to be ready for. And he said, "Do you mind if I get dressed first before we go out, so I'm not walking around in my pajamas?" And I said, "Sure." So he goes to put his pants on, and I said, "Why don't you sit down to put your pants on?" He says, "Oh, that's a good idea." So he sits down, he starts putting his pants on, and he gets this sort of glazed over look on his face. And I said, "Are you okay?" And then all of a sudden, everybody runs in the room, all the nurses and the whole rapid response team. And the doctor says, "Stand back, his defibrillator's going to go off." Bam. It defibrillated him. He was fine after that, but he did not get to go home until the next day. So he was really disappointed too. But it was exciting, and he was fine because he had that indwelling defibrillator. So I was really glad that I told him to sit down and put his pants on, though, so he didn't fall when that happened. And I was really glad that he wasn't out walking his dog when it happened, too. So cardiac arrest, it doesn't mean that your heart has to go to jail. It means cessation of all heart activity, no conduction of impulses whatsoever. It shows up as a flatline EKG. So tons of reasons why you could have cardiac arrest. Excessive vagal nerve stimulation, potassium imbalance, like we talked about in the electrolytes chapter, cardiogenic shock, drug toxicity, insufficient oxygen, respiratory arrest, which then leads to cardiac arrest, a traumatic blow to the heart, like being in a car accident. All those things can cause cardiac arrest. Congestive heart failure. Oh, on the subject of cardiac arrest, of course, we all know what we do in the case of cardiac arrest. We do CPR, right? So I learned a really fun fact at my CPR recertification this last summer. Washington State has the highest percentage of people who are trained in CPR of any state in the country. And it's the highest by far. Like all the other states, the average percentage of people trained in CPR is 4 to 6%. In Washington, it's 60 to 80%. So we're doing it right here in Washington. If you're going to have a heart attack or sudden cardiac arrest, this is the place to do it. Now you cannot graduate, as of last year, you can't graduate from high school in Washington without being certified in CPR. And I guess the city that has the highest number of people, the highest percentage of people certified in CPR is Seattle. So Seattle's probably the best place in the country to have a heart attack, and the worst place in the country to just faint from something else, because somebody will probably start CPR on you. But that just blew me away when I heard that. Anyway, all of us are certified in CPR. Isn't that great? So congestive heart failure, the heart is unable to pump out sufficient blood to meet metabolic demands of the body. It's usually results as a complication of another cardiopulmonary condition, and it may involve a combination of factors. So there are various compensation mechanisms that maintain cardiac output, and some of these aggravate the condition, so that's not fair at all. So in this picture, there's the normal heart and the thickness of the myocardium. You can see, well, the congestive heart, the myocardium is hypertrophied to try to meet the metabolic demands of the body, and so now there's a lot less room for blood to fill up in the ventricles. So that's a bad thing. The heart can't maintain its pumping capability. Cardiac output or stroke volume decreases. So less blood reaches the various organs. You get decreased cell function, fatigue and lethargy, and mild acidosis because you're not removing the byproducts of cellular metabolism as quickly. The backup and congestion develop as coronary demands for oxygen and glucose are not met. The output from the ventricles is less than the inflow of blood. So you get congestion in the venous circulation draining into the affected side of the heart. This is a bad story. So if you have left-sided congestive heart failure, The left ventricle weakens and it can't fully empty. So it decreases cardiac output to the system, to the systemic circulation. Decreased renal blood flow stimulates the renin-angiotensin-aldosterone secretion, which increases your blood pressure, right? It increases your peripheral resistance, making it even harder for your heart to pump. So you get backup of blood into the pulmonary vein, and high pressure in the pulmonary capillaries leads to pulmonary congestion or pulmonary edema. So that's the pulmonary congestion from the left-sided congestive heart failure. When you have right-sided congestive heart failure, the right ventricle weakens and can't empty. So again, you get decreased cardiac output to the system. You get decreased renal blood flow that stimulates the renin-angiotensin-aldosterone cycle, increased peripheral resistance from that, backup of blood into the systemic circulation, because the output of the right ventricle is not as much as the inflow of blood. Increased venous pressure results in edema in the legs, liver, and abdominal organs. And very high venous pressure causes distended neck vein and potentially cerebral edema. So neither left or right congestive heart failure is a good thing. So there are forward effects and there are backflow effects. So the forward effects are similar no matter which side the failure occurs on. So the forward effects are decreased blood supply to the tissues and general hypoxia, which cause fatigue and weakness, and dyspnea, difficulty breathing, and shortness of breath. The compensation mechanisms are tachycardia, which makes it worse, cutaneous and visceral vasoconstriction, which also makes it worse, and daytime oliguria. Oliguria is decrease of urinary output, and that increases your fluid load, and that makes it worse too. So your compensation mechanisms are not helping. The backup effects of left-sided failure are usually related to pulmonary congestion, dyspnea, and orthopnea. Orthopnea is when you have trouble breathing when you lie down. So ortho usually has to do with your position. So positional breathing difficulties, basically, because fluid accumulates in the lungs, so you have that difficulty breathing. A cough associated with the fluid irritating the respiratory passages, and paroxysmal nocturnal dyspnea, which is acute pulmonary edema causing dyspnea developing during sleep. So excess fluid in the lungs can also lead to infections such as pneumonia. So it's not a pretty picture. The right side failure and system backup, you get dependent edema in the feet, legs, or buttocks. So when the feet and legs are down, or when you're sitting, you get that edema going on. Increased pressure in the jugular veins, and so they're distended. You get hepatomegaly and splenomegaly, the enlarged liver and spleen, and that can cause digestive disturbances. You can get ascites, which is fluid accumulating in the peritoneal cavity, and you see marked abdominal distension with this. Acute right-sided failure causes a flushed face, distended neck veins, headache, and visual disturbances. So also not a pretty picture. This is the chart from the book that compares left-sided with right-sided in terms of causes, effects, signs, and symptoms, including the forward effects, the compensations, and the backup effects. So the main differences between the two are in the backup effects. The forward effects and the compensations are the same between the two. The left-sided heart failure backs up into the lungs. The right-sided heart failure backs up into the systemic circulation.